Excluded from the study were infections that were identified and were usually treated with a much longer course of antibiotics, such as Pseudomonas, Acinetobacter, and those that you can see listed there. Patients with bacterial endocarditis, deep abscesses, brain abscess, etc., were again situations where you treat for much longer and were not in the protocol. Also, patients who had antibiotic therapy starting more than 48 hours or more prior to enrollment were excluded, and patients with known chronic localized infections. Severely immunocompromised patients, patients on immunosuppressive therapy, and those who had life support withheld or to be withheld were excluded from the study. If you look at the rate of decline of procalcitonin, it seemed to be the same in both groups, which is typical of what you see with appropriate therapy in most of the patients. On this graph, you see that the PCT-guided group showed significant reduction in antibiotics at day 7 and 10 compared to the treatment as usual control group. On this table, what you're seeing is the difference between the control group and the procalcitonin group and the relative difference or mean difference. And really the most significant changes were in the total antibiotic exposure and in the ICU length of stay. Of note, there was not an increased relapse rate and or adverse outcome if you were guided by procalcitonin versus standard of care. In conclusion to this particular study, an algorithm based on serial PCT measurement allows for more judicious antibiotic use in patients with severe sepsis and septic shock. There's reduced antibiotic exposure, reduced lengths of hospital and ICU stay, no difference in the 28-day mortality, clinical cure, and infection relapse rates were observed, and they recommended a multi-center trial enrolling a large number of patients with severe sepsis and septic shock to test the PCT guidance protocol and its effect on ICU length of stay to validate the data. Summarize that, and the results would suggest that a protocol based on serial PCT measurements allows for a reduction in antibiotic treatment duration and exposure in patients with severe sepsis and septic shock without apparent harm. So to summarize what we've been through so far, procalcitonin, the 116 amino acid precursor peptide of the hormone calcitonin, has about a 20 to 24-hour half-life. It may modulate septic shock. It may have a pro-inflammatory effect seen in animal studies. It has a theragnostic value, I believe. There is now a rapid turnaround test using the virus ELISA test and measuring the PCT for clinically relevant bacterial infections and sepsis is possible now, which may help in risk assessment in the ICU and emergency room, and it's felt to be useful in determining efficacy of treatment and also in ruling out viral infection. Potential utilities are helpful in early diagnosis, risk assessment, prognosis of disease, and probably help in following a response, as well as guiding therapeutic management. And that's the sunset over Clearwater Beach. At this point, I think we'll be able to take some questions.
Yeah, thank you, Dr. Amin. I had a couple of questions I might ask. Dr. Amin, it appears that you do, in fact, include PCT now routinely in your protocol for diagnosing and managing sepsis. What situations are there, if any, where PCT levels would not be helpful in an acutely ill patient that might require a rapid assessment?
I find them helpful if they're positive or negative. When we see patients who are critically ill or hypoxic pulmonary infiltrates, and oftentimes the initial feeling is that they have a pneumonia, but the PCT levels come back negative, less than normal or very low, over a 24-hour period, we usually get 3. At time 0, 12 hours and 24 hours. If they're negative, then it prompts us to look for other disease entities much more quickly. So I think a negative PCT can be very helpful. In certain situations when there is a risk of having a false positive, one has to be careful, but as we've said before, a single test shouldn't be used by itself, but in the clinical context, given the picture of whether this is possibly infection, sepsis versus inflammation from another source such as pancreatitis, it's helpful in differentiating. But there have been situations where it will be elevated and not necessarily due to bacterial infection. But the clinical picture oftentimes helps with that.
I also had a question typed in that had to do with PCT and viral versus bacterial infections. The question was that their intensive care doctor wanted to use it to separate the two, meaning negative PC would indicate viral and positive bacterial. And the question was, is that true?
Yes, there's data from European studies, specifically for viral versus bacterial meningitis, showing has very good data for sensitivity and specificity with its negative predictive value. If the PCT levels are normal and you have all the stigmata of infection information, then almost certainly it's going to be viral. Now, it could also be an infection like PCP, where the levels are very low, where PCT levels are not elevated. So again, if you have significant changes suggesting an infection, but the PCT level is negative, it could be a viral infection or it could be a protozoal infection like PCP. So you have to look for those things. And certainly in meningitis, it's been shown quite significantly to be a good discriminator.
There are a few audio questions. Would you like to take those?
Sure.
Thank you. The first question comes from Dr. Michael Lipman. Please go ahead.
I just was typing this in, but I'm curious as what the cost of this is and what the turnaround time is. Given 20 minutes, but the necessary for batching would possibly delay the result. Could you just tell us what the overall cost per test is?
Yeah. Our cost per test at our hospital, I believe, is about $25. The ER has access to real-time turnaround, so we get the test back. Yeah, the test takes 20 minutes, but realistically it takes about 45 minutes to an hour to get the result back. Really not much different than we have to take for a lactic acid, for example.
And then when serially, if you're following this to predict how long a patient needs to be on antibiotics, how often does it be required to be done daily, twice a day? What is your experience?
Our protocol right now asks for 3 tests in 24 hours, time 0, 12 hours, and 24. And if the level is elevated and or rising, we'll do them daily until they come down. Then we can go to every other day. And the European study is looking at using PCT to help guide antibiotic therapy, did them every other day. And usually when the level was down to a drop of 90% from the highest level or the initial level is when they would consider something antibiotic. So going every other day once they're coming down is fine. But I usually like to do at least 2 or 3 in the first 24 hours because they can be rising from a low level. Even in patients who are severely septic, we've seen low levels of less than 1, but more than 0.05, and then shooting up to 10, 12, or even more than that in the first 12 to 24 hours.
Thank you.
The next audio question comes from Paul Hoyt. Please go ahead.
We're interested in the significance of the FDA statement that this is to be used in the first day in ICU. Does that mean it's not licensed to be used out of ICU?
I couldn't tell you how the FDA would define that. They describe critically ill patients. So we do, critically ill patients are seen in the emergency room, in the ICU, and oftentimes they're initially seen on the floor and moved to the ICU setting. We've not restricted it to be used just in the ICU. We are using it as a test. It's drawn in a simple chemistry tube, so it can be done with any chemistry test on that blood sample, and we haven't restricted it to the ICU as yet. The FDA labeling is the FDA labeling, but at our hospital we haven't restricted it to just the ICU. And you'd be surprised, people have asked for it outside, it's been high, and they've been moved to the ICU because of a high level consistent with more than just a localized infection.
Thank you.
Welcome.
I see one more question typed in, and that is, what does SIRS, S-I-R-S, stand for?
Systemic Inflammatory Response Syndrome.
And along the continuum, where does that fall?
Well, that's the earliest part of recognizing sepsis. So that's when the patient has very early signs of potential infection, which is basically an elevated heart rate, maybe elevated respiratory rate, white count, and fever or hypothermia.
Okay. Another question, Dr. Amin, do you ever use this test in conjunction with lactate?
Yes. In our sepsis protocol uses lactic acid as well as the algorithm that we have for procalcitonin. Lactic acid is a reasonably good marker, but not the best marker for catching early sepsis. And we're looking at our data retrospectively to see how they correlate. We haven't got to the final data analysis yet, but that'll be interesting to see. I suspect it will be very interesting and maybe beneficial to combine them.
Well, then if there are no other questions, I think we'll go ahead and conclude today's webinar. We appreciate your participation in our conference today.